First, I have to disclose I lectured for Bracco, Toshiba, and Samsung. When we talk about clinical indication, we have to start taking into consideration that Bernard stated in his introduction to the study of experimental that experimental medicine is nothing more than a reasoning by means of which the ideas undergone through the control of facts. How to do that? We may use data deriving from experimental study based on a large population of patients, or even more better, by using evidence-based guidelines. To now, the only one guidelines that is present in literature is the one provided by EFSUM experts in 2011 on CEUS non-hepatic application. And it is a pleasure and an honor to announce that in July we are going to be together, all the experts of EFSUM, trying to do an upgrading of those guidelines. If you look at carotid artery stenosis evaluation, we know that color Doppler is considered nowadays the first-line imaging modality in case of suspected carotid artery disease. However, we know that still color Doppler has some limitation, and there are some fields in which CEUS is very effective to improve the quality and accuracy of color Doppler, especially when we have to distinguish occlusion from tight stenosis, when we have to improve the delineation of endovascular border, and also when we have to evaluate ulceration of the plaque. And if you look at the recommendation provided by EFSUM, the highest level recommendation, B, grade B, is when we have to evaluate carotid plaque neovascularization, which means high-risk carotid plaque. Then we have again recommendation B by 3 and 3, when we have to distinguish carotid occlusion from residual flow in tight stenosis, or when we have to improve the lumen delineation when there are technically difficult carotid artery evaluation. Let's see an example. At baseline ultrasound, it is very difficult to understand which is the grade of this stenosis. But when we inject contrast agent, it is very easy to determine the grading of this stenosis. Another case in which at color Doppler, we were not able to distinguish occlusive from tight stenosis. Then we injected contrast agent. Here is the time that is going on. The contrast agent is fulfilling the carotid artery, and here it is, the possibility to determine that this was a tight stenosis, but not occlusive carotid artery. Let's move on to the other possible application, plaques vascularity. It has been proved in literature that by means of contrast-enhanced ultrasound, we may better demonstrate the neovascularization of the plaque. What means? Means that this is a very high-risk plaque. So far, we have to treat it as proper as possible. Let's see an example. Axial color Doppler already show that there is a tiny vessel within this hypoechoic plaque, but it is clearly visible when we inject contrast agent how nicely you can depict the border of this plaque. And waiting some seconds, you see that there are some vessels that are neovascularizing the upper part and outer border of this plaque. So this is a neovascularized plaque. But let's move on to the main indication of contrast-enhanced ultrasound. If you look at the recommendation grade, the highest level is when you have to deal to detect and characterize endoleak after abdominal aortic repair. Then also, if you have to follow up these patients, while lower grade of recommendation is also in the case in which you could improve the detection and the characterization of dissection of common internal carotid artery, vertebral arteries, and also abdominal aorta. However, we have to take into account that there are some limitations in CEUS exploration, And these are the same one that you could have with baseline ultrasound. For instance, extensive wall calcification and subcutaneous emphysema after intervention should be limitation of our examination. Looking at literature, in the field of the diagnosis of abdominal aortic dissection, Dirk Levert from Munich published a very nice study in which they compared color Doppler, CEUS, and CTA. What they did find, they found that CEUS were more accurate than color Doppler, rivaling with CT in order to discriminate dissection, especially in order to identify true from false lumen. Let's see an example. Baseline and color Doppler already detect the shotgun barrel appearance. However, when we inject contrast agent, and in this case we used also VRI, vascular recognition imaging, which is a polychromatic quantification software, which may help us to discriminate the inflow from outflow and also to determine which is the true from the false lumen. Also, the same image by using low MI index contrast examination. However, these are subjective evaluation. But nowadays, thanking technology, we may have quantitative perfusional software which help us to determine by using some ROI within the two lumen, and then we can see this time intensity curve, which may help us to better discriminate true from false lumen. And here is the same case as proven at CTA. But let's move on abdominal aortic aneurysm treatment patient. Currently, we have several imaging modalities by means by which we can determine the outcome or not of those patients. There is still much debate about which is the main and the best, the most indicated imaging modality: color Doppler, CTA, MRA, or CEUS. What we have to do in this kind of patients? We have to follow up either by means of evaluation of endoprosthesis patency, endoleak detection, the presence and the type, then the evaluation of residual aneurysmatic sac, then the evaluation of endoprosthesis by evaluating the positioning, the caliber, and the angulation. So far, to the imaging modality examiner, it is asked to measure aortic aneurysm diameter to detect any morphological details of the stent-graft, and again, the most important thing is to detect and classify the presence of endoleak. How can we do that? We use ultrasound, but the best imaging modality to detect and to measure the diameter has been considered CTA. However, nowadays we have also other possibilities. In literature, some paper, like the one from Ten Bosch, demonstrated that when you use ultrasound and CEUS, and you compare those imaging modalities with CTA in order to determine the diameter, you may achieve a difference that is not so high, and also you may have low inter-observer variability. What about the future? Nowadays, we have also the possibility to do what is called a diffusion image. What means? This is a tool that allows real-time visualization of ultrasound scan together with CT and MRI. And in this way, we can be sure that we have done a good measurement of the aneurysmatic sac. But let's move on to the detection and classification of endoleak. We know that endoleak is the most frequent complication of any EVAR. It may occur in a range between 15 to 45% of patients after initial repair. It is described as a persistent blood flow within the aneurysmatic sac, but outside the stent-graft. And one of the major Eurostar registry reported that it could be a possible complication in 9% of secondary intervention after EVAR at a mean time of 12 or 13 months. We may classify endoleak according to the appearance time And we may discriminate early from late endoleaks depending on the appearance. If it appears before 30 days after intervention, we may call it early endoleak. If it appears later than 30 days, it is called late endoleak. But most importantly, we may and we have to classify the different endoleaks in 4 or 5 types, depending on the source of blood in the periprostatic space. We call type 1 when it is due to incomplete adhesion between prosthesis and vessel wall at the proximal or at the end. The causes are inadequate choice of patients, inadequate choice of endograft, and physician experience. Here is an example in which you can see that the endoleak, the presence of blood flow, is outward the endoprosthesis at the proximal end part of the endoprosthesis, as you can depict in this very nice image at CEUS or at CTA. Second type, most frequent, is due to the collateral flow from lumbar or inferior mesenteric artery. Here is the presence of endoleak, which is not connected to the endoprosthesis, which appears usually after 10, 15, 20 seconds later than the arrival of the contrast agent within the endoprosthesis. And here is another case in which is very clear the presence of the lumbar artery, which fulfills the endoprosthesis and then comes out through the inferior mesenteric artery. Type 3 is due to graft defects, due to junctional leak or modular disconnect or fabric disruption. Here is a case in which you can see the endoprosthesis and there is the disruption, and soon after, contemporary at the arrival of contrast agent, you see the arrival within the sac. And here is another case of CTA and the corresponding leak, and this is a case that for which I have to thank Dirk Levert. Type 4, due to porosity of the end of the prosthesis, it is extremely rare and it is usually very early. This is a very old case by means of angiography, which shows the porosity. And here is again another case from Dirk Levert, which clearly shows the presence of multiple refilling inside the aneurysmatic sac. Type 5, this is under question. Some authors call it type 5. Some others say that this is only not detectable endoleak or sealed endoleak, virtual endoleak. Here is a case that CTA called as negative, but then aneurysmatic sac increasement, and then we detect at CEUS the presence of endoleak. What about literature? There is a meta-analysis published by Mirza in which they collected 21 studies, including 2,601 patients, and they showed that sensitivity and specificity of CEUS was significantly higher color Doppler ultrasound and significantly comparable with CT. And also, they suggested that it appears that CEUS could be a very ideal imaging modality in these fields. However, further studies at that time was warranted. Our study, a prospective evaluation by using CTA, MRI, and CEUS, and also we showed that we increased significantly the sensitivity and specificity of color Doppler, rivaling with CT and MRA. However, we have to state that there are some limitations, and these are the same one that you have with ultrasound. Obese patients, meteoric patients, sometimes the gas after treatment may produce some false or negative or positive results. Let's try to put this imaging modality in some clinical scenarios. The first one, you have negative color Doppler, but patient is symptomatic or has an aneurysmatic sac increasement. So what you do? You have this case in which you see just this lumbar artery. You see that we reduced at very low level PRF in order to detect any tiny vessel within the endoprosthesis. But then We injected contrast agent, and you see time is going on, and clearly you can depict this endoleak within the sac, and also you can depict the lumbar artery, which refill the aneurysmatic sac, and this was a type 2 endoleak, as confirmed at CT and MRA. Positive color Doppler, or suspicious for endoleak, but it is true or not. In this case, we don't know if it is artifact or it is a true endoleak. We injected contrast agent, and we did not detect any endoleak during the whole examination. This was confirmed negative patient. CT identified dimensional increase of aneurysmatic sac, but no clear endoleak, as in this case, probably due to the hardening, the beam hardening artifact. MRI showed this endoleak, and CEUS showed this very nice endoleak. Again, CTA negative, but probably this was only done at that time during arterial phase. MRI and CEUS depicted nicely this endoleak. Also, we may achieve better characterization of hemodynamic behavior or contrast medium because it allows real-time imaging evaluation. This patient was treated in 2011, then came to our evaluation. We did detect aneurysmatic diameter increase. We inject contrast agent, time is here, and you see here, it is clearly visible, the presence of endoleak. But what can we do? We can continue with the examination. We can also use flash, so far high mechanical index disruption. Then with some software, we may trace the migration and the direction of the contrast agent. And even more, with new technology, we may use this polychromatic software. And you see red is the flux that is coming from the back to the upper part, and in blue, the conversely appearance. You see red, red, and then blue. So this is the part from lumbar artery, the income part, the outcome part, inferior mesenteric artery. And this was confirmed at CTA. But again, even more, new softwares. Look at here, timing. The endoprosthesis is fulfilled, timing is going on, and after 10 seconds, you see there are some microbubble within the aneurysmatic sac. But we may achieve better results by using polychromatic software like this one. The colors correspond to the timing, and you see that the endoleak is colored in blue. Here it is. Means that appears 12 seconds after the arrival within the endoprosthesis. Another case, CTA called as probably type 1, but we do also 3D, different planes, in real time you can see the fulfillment of this endoprosthesis and aneurysmatic sac. Again, in patients in which you cannot do MRI, for instance, because there were too much artifacts, you can do your examination with CEUS. You can achieve these very good results showing the presence of endoleak. Again, you can flash and you can have the refillment. What about the 3D? There are some papers in literature which are showing that you can better classify endoleak by using 3D comparing with 2D. Here is an example, and you see that we can follow in all the planes the presence or the absence of this endoleak. In conclusion, CEUS should be considered low-cost, safe tool which provides dynamic real-time evaluation of blood micro and macro flow, better detection of slow-flow endoleaks, higher accurate than color Doppler, equal or better sensitive than MRA and CTA. However, it is still an ultrasound examination, and we hope that new technology with 3D and the fusion imaging may help us to achieve better results. We have to implement this technique in the right workup. How to do that? Recently, we published this paper in a special issue on CEUS. I was together with Stephanie Wilson, the guest editor of this special issue. We collected experience from Clevert, Iezzi, Ayani, Martegani, and others. And we suggest the follow-up. We suggest to do CT, MRI, and or CEUS before the discharge, then following this patient with CEUS at 3-6 months, and if we find something that needs to be treated, like an endolic type 2 with an increasement of an aneurysmatic sac more than 4 mm, we have to treat. Otherwise, we may do wait and see. Or if you see type 1, type 3, you have to do CT, MRI, CEUS fusion, and then treat. At the end of this talk, I ask you, what kind of imaging modality you prefer, Ferrari or a stealth? I thank all of you, all my group, for the kind attention. And also, I remind you that we are going to organize the next Eurozone in Leipzig in October 26-29. Thank you so much.